بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. Today our lecture is about disorders of adrenal cortex. In this lecture we concentrate on adrenal hyperfunction. The lecture will be presented by Dail Ibrahim Wakiallah, Assistant Professor of Clinical Chemistry. Adrenal dysfunction, mainly adrenal hyperfunction, is mean increased function of the adrenal gland. This increase can be presented in many disorders. What we are going to talk about Cushing syndrome, which is characterized by high cortisol, Hyper-Algistorianism. This condition is characterized by high aldosterone, and pheochromocytoma, which is characterized by high catecholamines production. Hyper-Algistorianism. This is a medical condition where too much aldosterone is produced by adrenal gland, which can lead to sodium retention and potassium loss. Can be of the two types, primary hyperaldosteronism or secondary hyperaldosteronism. Primary hyperaldosteronism, here we have hyporenemic and hyperaldosteronism. This condition is also known as Conn's syndrome. Conn's syndrome characterized by autonomous excessive production of aldosterone by adrenal gland, present with hypertension, hypokalemia, alkalosis, renal potassium wasting. Causes of Conn's syndrome: adrenal adenoma, bilateral hypertrophy of zona glomerulosa cells, adrenal carcinoma, which is a rare cause. Secondary hyperaldosteronism is increased adrenal production of aldosterone in response to non-pituitary extra-adrenal stimulation, increased renin secretion, hyperrenemic hyperaldosteronism, commoner than primary aldosteronism. Common causes of secondary aldosteronism: CHF, congestive heart failure, liver cirrhosis with ascites, nephrotic syndrome. Less common causes can include renal artery stenosis, sodium losing nephritis, renin secreting tumor. The clinical feature of Conn's syndrome include hypertension due to aldosterone-induced sodium retention with increase in ECF volume, muscle weakness due to decreased potassium, muscle paralysis, severe hypokalemia, latent tetany and paresthesia, polydipsia, polyuria and nocturia due to hypokalemic nephropathy. Investigation for Conn's syndrome: electrolyte and blood gases. We find hypernatremia and hypokalemia, alkalosis, urinary potassium loss level more than 30 millimole daily during hypokalemia. Also, we can measure plasma aldosterone renin activity. After that, we calculate the ratio. This is a sensitive screening test. No need to standardize Porcher ratio. If the ratio is less than 800, diagnosis is excluded. We seek other causes. If the ratio is more than 1,000 and less than 2,000, diagnosis is possible. We need to do a confirmatory test. And if the result of the ratio is more than 2,000, diagnosis is very likely. After that, we establish the cause. Diagnosis: perform saline infusion test, sodium loading method, infusion of 1.25 liter of 0.9 saline over 2 hours. Result: plasma aldosterone remained high or more than 240 picomole per liter, confirm Cone syndrome. Here the test is based on the suppression of excretion of aldosterone due to high sodium. So in the patient of Cone syndrome, there is no response to the high sodium level, and the plasma aldosterone remain very high. Plasma aldosterone level method: morning blood sample, patient stayed recombinant since walking. Second sample after 4 hours, stay ambulant, standing, low renal blood flow, stimulate renin secretion. So we have high aldosterone. Also, we can establish the cause by imaging technique like CT scan and MRI can differentiate adenoma from hyperplasia. Treatment of Cone syndrome: tumor removed surgically, bilateral adrenal hyperplasia. We give the patient spironolactone drug. The second disorder in which the adrenal is hyperfunction is Cushing syndrome. Here we are going to talk about definition, clinical feature, investigation, screening for Cushing syndrome, elucidation of cause of Cushing syndrome, and management. What is the Cushing syndrome? Adrenal cortex hyperfunction, or any condition resulting from overproduction of primarily glucocorticoid cortisol hormone. Mineralocorticoid and androgen may also be excessive. Pseudo-Cushing syndrome appear Cushionoid and have some biochemical abnormalities of true Cushing disease. The causes is severe depression, alcoholism, obesity, polycystic ovarian syndrome. The etiology: excessive cortisol, ACTH dependent, 75% pituitary disease. Adenoma represent 90%, hyperplasia is 10%. Ectopic ACTH syndrome, malignancy of the following organ: bronchia, thymus, pancreas, ovary. Ectopic CRH syndrome, exogenous ACTH administration. All these can be causes for Cushing syndrome. Cushing disease, this is ACTH dependent causes. ACTH secretion is increased, pituitary insensitive to feedback by normal level of cortisol, high level of cortisol required to be produced, negative feedback on ACTH, but there is no response, so ACTH is still increased. Ectopic ACTH secretion, high level of ACTH secreted by tumor stimulate excessive cortisol production. Secretion ACTH by pituitary inhibit Here we have hypertension of ACTH and cortisol is greater. The hypersecretion of ACTH and cortisol is greater in ectopic ACTH syndrome than in Cushing disease. Excessive cortisol, ACTH independent, it is found in or represent 25%, can be by adrenal tumor, either adenoma or carcinoma, nodular hyperplasia, exogenous glucocorticoid administration. Adrenal tumor, autonomous cortisol production, high circulating cortisol inhibit ACTH secretion. In the normal condition, when is a high cortisol, this is inhibit ACTH. In the independent ACTH condition, the production of high cortisol can suppress ACTH secretion. Excessive cortisol, as we mentioned, it is represent 25% of cases, can be by adrenal tumor, adenoma or carcinoma, nodular hyperplasia, exogenous glucocorticoid. Excess cortisol binding globulin, estrogen therapy, osteoporosis, and pregnancy. The most important for diagnosis of Cushing syndrome is the clinical feature. The patient with Cushing syndrome has clinical feature which is easily distinguished from other causes or other conditions. Number one, they has truncal obesity with deposition of adipose tissue in characterized sites. This is known as moo face and buffalo hump. Exact mechanism is unknown. Also, the patient with Cushing syndrome have or has thinning of skin. This is a catabolic response. Have purple striae, catabolic response. Excessive bruising, catalytic response. So in these two pictures, the picture in the right hand is typically of face moon feature of the patient with Cushing syndrome, and the picture in the left side demonstrate purple striae, which is the red or pink color straight line appear or lines appear in the skin of the patient with Cushing syndrome. Continues for clinical feature. Also, the patient present with hirsutism, especially adrenal carcinoma, due to high adrenal androgen, menstrual irregularities, also due to high adrenal androgen, skin pigmentation, ACTH high, melanocyte stimulating activity due to high ACTH, hypertension due to mineralocorticoid effect on sodium, so it causes sodium retention, potassium wasting. This is lead to hypokalemia and alkalosis, glucose intolerance due to high hepatic gluconeogenesis and insulin resistance, muscle weakness and wasting. This is catabolic response in peripheral supportive tissue. Also, the patient have back pain due to osteoporosis and vertebral collapse, inhibit bone formation, psychiatric disturbance, euphoria, mania, and depression. Here in this picture, we can summarize the clinical feature of the patient with Cushing syndrome. Cushing syndrome can affect the emotional disturbance, enlargement cella thoracica, moon phase, osteoporosis, cardiac hypertrophy. This is lead to hypertension, buffalo hump, obesity, adrenal tumor or hyperplasia, thin, weak skin, abnormal stria, menorrhea, and muscle weakness. And finally, they have skin problem, can be presented as skin ulcer, poor wound healing. Also, they have purpura. Laboratory investigation for Cushing syndrome. There are two diagnostic steps in the investigation of patients suspected of having Cushing syndrome: screening test and then identification of the cause. Screening test can be done for identification of Cushing syndrome, the demonstration of high plasma cortisol level. After we have high cortisol level, then we are going to identify the exact cause for this increase in cortisol level. Demonstration of increased cortisol. This can be done either by assessment of circadian rhythm in cortisol secretion, 24-hour urinary free cortisol excretion, overnight low dose dexamethasone suppression test. Number 1, assessment of circadian rhythm in cortisol secretion. The cortisol is have what is known of circadian rhythm. This is a biological feature in which some constituent can be increased at time during the day and decrease in other time during the day. So in cortisol we measure 8 a.m. and 11 p.m. serum cortisol. If the patient is normal, serum value at midnight is decreased 50% less than value at a.m. So the rhythm for cortisol is increased in morning and decreased in the midnight. So this feature is used to diagnose Cushing syndrome. We measure cortisol 8 a.m. morning and 11 p.m. in the evening. In patient with Cushing syndrome, rhythm is lost and pseudo Cushing normal circadian. Measuring 24-hour urinary free cortisol. In this we have 3 interpretation of result. If the result is less than 300, this result is normal. If the result is fall between 300 to 700, severe depression stress. If the result is more than 700, diagnostic of Cushing syndrome. Number 3, we do also low dose dexamethasone suppression test. We give the patient 0.5 milligram dexamethasone oral, giving 6 hourly for 2 days. The dexamethasone is synthetic cortisol, blood for plasma cortisol collected 6 hours after last dose. Urine for free cortisol is collected before and on the second day of DEXA. Result: urinary free cortisol suppressed by 50%, less than 70 nanomole per 24 hour. Normal plasma cortisol suppressed less than 140 nanomole. This is pseudo Cushing, no suppression cortisol. This is Cushing syndrome. So in summarize, this test is used to differentiate Cushing syndrome from Cushing disease. As we mentioned, we give the patient synthetic cortisol, which is known as dexamethasone. We give the patient 0.5 milligram dose, 6 hours for 2 days. Then we collect urine for measurement of free cortisol. The result suppressed by 50% in normal plasma cortisol and in normal, and plasma cortisol suppressed to 140 nanomole in cases of pseudo Cushing, and in patient with Cushing syndrome, no suppression of urine free cortisol and plasma cortisol. Elucidation of the cause: high dose dexamethasone suppression test. Normal individual suppress plasma cortisol to less than 50 nanomole per liter. Patient with Cushing syndrome failed to show complete suppression of plasma cortisol. This test is highly sensitive. So, for the second time, high dose dexamethasone suppression test is also used for differentiate between pseudo or Cushing syndrome and Cushing disease. Plasma ACTH, we measure plasma ACTH. If the result is less than 50 nanogram per liter, this is a normal result. Low result was found in adrenal causes. Elevated is a can slide. This is pituitary dependent Cushing, and if it's gross, this is ectopic secretion of ACTH. CRH test. This test is used to differentiate ectopic ACTH secretion and Cushing disease. Cushing disease, plasma ACTH increase 50% over baseline and cortisol increase by 20%. In cases of ectopic ACTH or adrenal tumor, no response. The imaging: CT scan of adrenal gland in cases of adrenal tumor, MRI, CT scan and MRI of thoracic abdomen. This is preferable in ectopic ACTH producing tumor. Treatment of Cushing syndrome depend on Cushing syndrome and depend on the etiology. We have many choices for treatment: either adrenal adenoma, adrenal carcinoma resection. In case of Cushing disease, we do transsphenoidal hyposectomy, which is a surgical removal of pituitary gland. Drug to block cortisol synthesis like metropol. So this is all about adrenal hyperfunction. Either we have Conn's disease or Cushing disease. Now we reach the end of this lecture. Thank you for good listening and see you in the other lecture.